Important safety information for Aggrastat, tirofiban hydrochloride injection. Indication: Aggrastat is indicated to reduce the rate of thrombotic cardiovascular events, defined as combined endpoint of death, myocardial infarction, or refractory ischemia, repeat cardiac procedure in patients with non-ST elevation acute coronary syndrome. Contraindications of Aggrastat include a known hypersensitivity to any component of Aggrastat, a history of thrombocytopenia with prior exposure to Aggrastat, those with active internal bleeding or a history of bleeding diathesis, major surgical procedure, or severe physical trauma within the previous month. Warnings and precautions. Aggrastat can cause serious bleeding. Most bleeding associated with Aggrastat occurs at the arterial access site for cardiac catheterization. Minimize the use of traumatic or potentially traumatic procedures, such as arterial and venous punctures, intramuscular injections, nasotracheal intubations, etc. Concomitant use of fibrinolytics, anticoagulants, and antiplatelet drugs increases the risk of bleeding. If bleeding cannot be controlled, discontinue Aggrastat. Thrombocytopenia, discontinue Aggrastat and heparin. Bleeding is the most commonly reported adverse reaction. For additional information about Aggrastat, please refer to the full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.
Hi, everyone. I am Kevin Ariani. I'm an interventional cardiologist, mostly practicing at Dignity Northridge Medical Center and Providence Cedars-Sinai Tarzana Hospital, as well as West Hills Community Hospital. I am the cardiovascular director at Dignity Northridge Hospital, and I'm going to present a case using Aggrastat for acute coronary syndrome for a patient who was not adequately preloaded with an anti-platelet medication. Purpose of this video is to demonstrate a typical use of Aggrastat for fellows and those who may not be familiar with contemporary use of 2B3A inhibitors. Here are my disclosures. I received financial support from Medicure for creation of this video. Patient is 53-year-old male who presented with acute anterior wall myocardial infarction to the emergency room. Per records and description of the emergency room physician, patient was hemodynamically unstable, and when I reached the patient, he was having crushing chest pain and blood pressure was quite labile, and he was having ventricular arrhythmias. Patient was immediately transferred to cath lab. Right wrist access was used. CLS 3.5 guiding catheter was used for imaging, which revealed 100% occlusion of proximal LAD. As we were preparing with the wires and balloons, patient was immediately loaded with 25 microgram per kilogram of Aggrastat bolus and immediately started on Aggrastat drip. Before going to the case, I want to point out that the main problem with oral P2Y12 inhibitors is the lag of time for them to reach therapeutic levels of platelet inhibition. This usually takes several hours. Even for ticagrelor and prasugrel. And as you know, sometimes having opiates causes their absorption to be delayed. So this is the pharmacodynamic data from 24 high-risk ACS patients undergoing PCI. Aggrastat or tirofiban is a reversible antagonist of fibrinogen. It binds to the glycoprotein 2B3A receptor, where it blocks it's the final common pathway to platelet aggregation. Aggrastat's half-life is approximately 2 hours. Platelets return to normal function between 4 to 8 hours after stoppage of infusion. Aggrastat provides very potent and rapid platelet inhibition. 96% of platelet inhibition occurs within the first 10 minutes. Aggrastat is very consistent response amongst patients. 73% of patients reach greater than 95% of inhibition within 10 minutes. ACC, AHA, and SKY guidelines provide a class 1A recommendation to use a GP2B3A for non-ST elevation or ACS or patients undergoing PCI who are not adequately pre-treated with clopidogrel or ticagrelor. So back to our case. Here, how we decided to proceed. After the Aggrastat was started and patient was heparinized, we did initial balloon angioplasty followed by placement of a 38 millimeter by 3.5 millimeter synergy stent in proximal LAD. Results were excellent with TIMI grade 3 flow. Patient became asymptomatic and remained in an excellent health and condition throughout his admission and was discharged home. The takeaways from this case are Aggrastat IV bolus infusion allows for rapid and potent antiplatelet action in a situation when no or inadequate platelet therapy exists. As well, Aggrastat IV infusion time can be modified to allow transition to oral antiplatelet therapies based on the patient's ability to take an oral medication at the time of the intervention. Thanks for watching this video. In case you have any questions, please reach out to your Aggrastat team for more information. Have a good day.